Hello everyone, hope you're doing well today. Today we're going to be covering the ICECAP study. First, we will start off with the study basics, and then we will delve into the background, and then discuss inclusion-exclusion criteria, and finish off with looking at the RA role for the study. Let's first start by looking over the study basics. So ICECAP stands for Influence on Cooling Duration on Efficacy in Cardiac Arrest Patients. And the two principal investigators for this study are Dr. Matthew Greer and Dr. Daniel Nishijima. The purpose of the study, as stated on the one-page summary, is to determine the following two objectives in each of the two populations of adult comatose survivors of cardiac arrest. So the first of these two populations are those with initial shockable rhythms, and the second are those with PEA, or pulseless electrical activity, or asystole, which are unshockable cardiac rhythms. And this means that there is a very small chance of defibrillation actually working. The first of the two objectives for this study is to find the shortest duration of cooling that provides the maximum treatment effect. And this is determined by a weighted 90-day modified Rankin score, which is used to determine the degree of disability in patients who've had a stroke. So for the score, patients receive a score from 0 to 6, with 0 meaning no significant disability, 5 being severe disability requiring constant care, and 6 meaning death. So this study is also seeing whether increasing durations of cooling are associated with better outcomes or recovery, implying efficacy of hypothermia to no cooling. Now let's look at the background of this study, which will better place the purpose that we discussed into perspective. So first we'll begin by talking about cardiac arrest. So cardiac arrest is the abrupt loss of heart function, breathing, and consciousness. And in the United States, there are more than 350,000 cases of cardiac arrest. And cardiac arrest is often used synonymously with heart attack. However, they do have different meanings. So heart attack or myocardial infarction occurs when blood flow decreases or stops to a part of the heart, causing damage to the heart muscle. So it's specifically focused on blockage to the heart, while cardiac arrest is the abrupt loss of total heart function, as well as breathing and consciousness. So a heart attack can lead to a cardiac arrest, but they do mean completely different things. So cardiac arrest is extremely serious, and if not treated within minutes, it can lead to death. So treatment of cardiac arrest involves one of two things. It's either cardiopulmonary resuscitation, or CPR, or defibrillation. Most cardiac arrests are caused by a heart's electrical system malfunction, which leads to arrhythmia, which is abnormal heart rhythm. Although in some cases this can happen in individuals who've had no known heart disease, usually arrhythmia develops in a person with a pre-existing or underlying heart condition, such as coronary artery disease or congenital heart disease. And there are several risk factors for cardiac arrest, and these risk factors are very similar to the risk factors of coronary artery disease. And this is because coronary artery disease can lead to cardiac arrest. So the risk factors include a family history of coronary artery disease, smoking, high blood pressure, high blood cholesterol, diabetes, and obesity. In addition, other factors such as age, previous heart attack or cardiac arrest, or nutritional imbalance can also increase the risk of cardiac arrest. Now that we've talked about what a cardiac arrest is, let's now talk about what happens after treatment. So, if the CPR or defibrillation is successful, then ROSC or return of spontaneous circulation is achieved. So, ROSC is the resumption of a sustained heart rhythm, and some signs that ROSC has been achieved includes breathing, coughing, and movement from the person who has experienced cardiac arrest. So, if ROSC is achieved, then the individual has a palpable pulse or a measurable blood pressure. Now, some individuals do regain consciousness after ROSC. However, some individuals, even after ROSC is achieved, might not regain consciousness and enter a comatose state. When a cardiac arrest occurs, there is reduced blood flow to the brain, which can cause brain damage. Therefore, to improve outcome for patients who are in a coma, they are cooled soon after their cardiac arrest. And this process is called therapeutic hypothermia, which is also known as targeted temperature management. Targeted temperature management, or TTM, is a treatment used in unconscious patients with spontaneous circulation and has been shown in previous research studies to improve the outcomes of these patients. There are multiple potential mechanisms that have been outlined to show how TTM prevents neuronal cell death. So one is that the cooling reduces cerebral metabolic rate, which in turn reduces the demand for oxygen in brain cells. Another is that the cooling can decrease the inflammatory response caused when the brain might have been initially damaged soon after the cardiac arrest. The procedure for TTM can be broken up into 3 phases. First, we have the induction phase, during which the goal is to achieve a core temperature between 32 to 34 degrees Celsius as soon as possible. Then there is the maintenance phase, where this temperature is held for 12 to 24 hours. And the final phase is the rewarming phase, where the core temperature is gradually raised by 0.2 to 0.5 degrees Celsius until it is greater than 36 degrees Celsius. Although previous studies have found that this treatment is successful for out-of-hospital cardiac arrest, the effectiveness of this treatment is still around 50%. Therefore, this study is trying to learn more about the treatment overall and potentially implement new procedures to improve the condition of patients who receive the treatment. Now that we have learned a little bit of the background regarding the study, we'll now look at the inclusion and exclusion criteria for ICECAP. So all of these inclusion criteria have to be met for the patient to be potentially eligible for the study. So the inclusion criteria is as follows. The first one is an age inclusion, and it states that the patient has to be greater than or equal to 18 years of age. The second one is that the patient has to be in a coma after resuscitation from a out-of-hospital cardiac arrest. In addition, the patient's temperature has to be less than 34 degrees Celsius within 240 minutes of cardiac arrest, and a definitive temperature control device has to have been applied to the patient's treatment. We also have to have an informed consent from LAR or legally authorized representative, including intent to maintain life support for 96 hours. And the final inclusion criteria is that the enrollment has to have occurred within 6 hours of initiation of cooling. To sum up the inclusion criteria, we're going to be looking for any patients greater than or equal to 18 years old who've had a CPR before presenting to the ED and sustains ROSC, so return of spontaneous circulation. And this patient must have been cooled within 240 minutes of their cardiac arrest via a definitive temperature control device. So this is the list of the exclusion criteria, and if any of the exclusion criteria is met, then the patient is not going to be eligible for the study. So the first is hemodynamic instability. So hemodynamic instability means that there's abnormal or unstable blood pressure, which can cause insufficient blood flow. And in most cases, this will require artificial slash mechanical support to maintain blood pressure. So ECMO, ventricular assist devices, IABP, are all mechanical devices that bypass or assist the heart in order to maintain blood flow. The second exclusion criteria states that patients with pre-existing conditions that confound outcome determination will also be excluded. So these conditions can include sepsis or pre-existing neurological disability. The last exclusion criteria states that patients with pre-existing terminal illness, such as cancer or DNR or do not resuscitate orders, will also be excluded from the study. So now we're going to be discussing the role of the RA regarding this study. For ICECAP, only the investigators are allowed to consent. Therefore, our responsibility as RAs is to screen for eligible patients and then report to the RC or ED providers regarding eligible patients. So when screening for ICECAP, we're going to be looking at the following two chief complaints for patients who've come in. So we're going to either be looking for a 944 or a medical emergency, or the chief complaint could also be ROSC achieved. In addition, we can also be looking for a banner of CPR or 944 on the EMR chart. We can also take a look at the show report label to get more information, such as ED triage notes, about the patients before entering a patient's chart. When we enter a patient's chart of a potential eligible patient, we can click on the narrator tab to find the time of cardiac arrest, the time of cooling, and if the patient has hemodynamic instability. Now let's talk about when we should be screening for ICECAP and who we should report to if a patient has been found who's eligible. Now, RAs can screen for ICECAP whenever we're in the ED. And if an RC or junior specialist is on shift when an eligible patient is found, we're going to alert the RC or JS, even if the principal investigators, so Dr. Greer or Dr. Nishijima, are not on shift. If the RC/JS is not on shift and an eligible patient is found, then we would talk with the attending physician about that patient and ask if the ICECAP team has been alerted. Now, if the attending physician is busy, then we can ask the resident if the ICECAP team has been alerted about the eligible patient. The treatment team calls Dr. Greer or Dr. Nishijima directly, even if they're not working on shift. Therefore, RA should never be calling either PI to notify them unless asked to do so by the attending physician. And that concludes the overview of the ICECAP study. Thank you so much for watching, and have a wonderful day.